Hi, my name's AUSON Ellis. I'm a graduate student at Auburn University, and today I'm going to be performing a head-to-toe assessment.
We obtained vital signs, and her vital signs were within normal limits. And we obtained a weight and her BMI. I'm looking at her general appearance and doing a visual inspection of her overall body inspection of her demeanor and her behavior, her build, and any obvious abnormalities, asymmetry, or lesions or injury. First, we're going to start with skin, and I'm going to inspect the skin. I'm going to inspect the skin for color, vascularity, hygiene, edema, or any injuries or lesions or birthmarks. And as I'm doing so, I do not see any abnormal deformities or any lesions. Then I'm going to palpate Stephanie's skin to see the temperature of her skin. Next, I'm going to inspect Stephanie's hair. And by doing so, I'm just looking for the distribution of her hair, the color, the quality. I'm going to palpate the scalp for any deformities, nodules, or masses, or any asymmetry. And I want to look all the way around. All right, everything looks good there. Thank you, Stephanie. Next, I'm going to look at her face and inspect her face for any deformities or lesions or asymmetry, and everything looks symmetrical. Then next, I'm going to inspect the head, the general size and the shape and symmetry. I'm going to palpate the skull for any depression or bulges or any lesions. And have you had any recent injuries to the head, Stephanie? So next, we're going to go and assess Stephanie's sinuses. First, I'm going to palpate her frontal and maxillary sinuses. Asking Stephanie, are you having any tenderness when I touch?
No.
All right. Now I'm going to observe her patency of her nares. Stephanie, can you put your one finger and include one finger on your nose and breathe for me? And then can you switch and do the other one? Okay. Breathing well. Now I'm going to assess the temporomandibular joint. And Stephanie, I'm just going to ask for you to open your mouth and close for me. And I want to palpate and see if there's any tenderness and no tenderness. All right, we have our septum is midline, no deviation, and the turbinates are nice and pink, and no irritation noted. And no drainage or mucus noted either on inspection. Next, I'm going to assess Stephanie's lips and mucosal and gums and teeth and the top of the palate and the bottom of the palate. First, I'll look at her vermilion border of her lips. Everything looks nice and symmetrical. All right, can you say ah, Stephanie? And I'm visualizing, and the uvula is midline and no indentation. I do not see any presence of cavities or dental carriers, and no redness or inflammation or any sores inside of her mouth at this time or lesions. We're also looking at the tonsils. Stephanie, when did you have your tonsils out?
2 years ago.
2 years ago? Okay, and we're going to visualize the posterior pharynx and look at the texture and abnormal movements of her tongue. Can you stick your tongue out for me? Just want to make sure she doesn't have any lateralization or any irregular shape in her tongue. Then we'll look for the sublingual glands and assess the rest. Can you say ah for me one more time? Can you lift your tongue up? All right. Now I'm looking at the palate of her mouth. Okay. Thank you. Okay, next we're going to assess the eyes, and I'm going to assess the alignment of Stephanie's eyes by the cover test. And this is going to be where we ask for to observe for eye movement. All right. And I'm assessing. All right. And then can you cover the other eye for me? Okay. No convergent squint or divergent squint. Next, we're going to inspect her eyes and her conjunctiva and sclera and cornea. Stephanie, can you pull your eyelid, your bottom eyelid down for me?
Yes.
And her conjunctiva is non-reddened and clear. And then I'm going to open her eyes up so I can visualize. So with the otoscope, you want to make sure that we have the proper dial in. I'm going to view the red reflex and optic disc and retinal blood vessels and macula and the fundus and all the anterior chambers. with the light, and then I'm going to come in. Alright. We're going to inspect her auricle and also palpate it. I want to put gloves on here too. Any pain or discomfort?
No.
And no drainage noted. And if I feel like I do suspect something or an infectious process, I will want to take my gloves off and wash my hands to move to the next process. First, I'm going to palpate the outer edge of both ears. Bring tenderness, any tenderness?
No.
All right, I'm going to lift up and back to visualize. And nice and pearly white. Next, we're going to test for lateralization using the tuning fork and bone conduction. This is the Weber and Ryan. Tell me when you do not hear the sound anymore, okay? And do you hear them in both ears?
Yes.
Equally?
Yes.
All right. And then we're going to check. I need you to tell me when the noise stops. And then I'll move it to your anterior side of your ear.
Okay.
All right. Then I'm going to do the same on the other side. So we're going to move on to the neuro and the cranial assessment, and starting with first assessing Stephanie's sense of smell and her olfactory nerve, and that'll be cranial nerve 1. I'm going to do so by handing Stephanie 2 different objects, and she can tell me what she smells.
Like sweet.
Mm-hmm.
And sour.
All right, that's right. Next, we are going to move to the optic nerve, and that will be assessing and inspecting Stephanie's pupils, and that will be cranial nerve 2. And we're going to look at the size of the pupils, and we're going to look for any aniscoria. With the cranial nerve 2, we're going to go into the assessment of her results of her visual acuity prior to coming into the office, and that was done by the nurses, and I received that you have a 20/20 vision in the right eye and 30/20 in the left eye. And Stephanie, do you wear glasses?
No.
If you do wear glasses, it's important to do so and use the glasses or corrective lenses during the exam. All this means is that you have 20/20 vision in your right eye, which is normal, and in your left eye, what you see at 20 feet is what most people can see at 30 feet. All right. So now we're going to look into her eye and double check and see if we see any cataracts or any abnormal wool bodies or any ocular media opacities. We're going to use the optoscope again. Okay. No abnormalities noted, no signs of macular degeneration, and vessels look good. Next, we're going to move on to assessing the visual fields, and this will be assessing for cranial nerve 2. I'm going to stand 2 feet apart from Stephanie, and then I'm going to have her cover her eye, and we're going to test an object mid between the patient and the examiner. We're going to do so an object checking from the periphery in approximately 8 directions. Okay. Stephanie, can you please close your right eye and cover your right eye? All right, I'm going to do the same thing. Tell me when you can see my finger, Stephanie.
Okay. No. Okay. Okay.
And keep your hand placed right there. Okay. And we're going to go.
Okay. Right. Okay.
All right, and you can switch to your next side. We're going to now test Stephanie's pupillary response and light, direct and consensual, and accommodation. All right, Stephanie. And we have consensual. All right, and next I'm going to do indirect, which will be consensual, and I'm going to check for pupillary reflex constriction in her opposite eye at this exam. Stephanie, I'm going to go ahead and cover right here. Next, we're going to check for accommodations. I'm going to ask Stephanie to stare something, an object of close up and an object further away. Stephanie, can you stare at my finger right here and then choose an object a little bit further away? All right, Stephanie, look at my finger, and then I would like you to look at the object far away. And then again. And then again. We want to make sure that our eyes are accommodating to short and long distance. Next, we're going to move to checking for extraocular movements, and this will test for cranial nerve 3, cranial 4, and cranial nerve 8. We're going to be doing this to make sure there's no abnormal movement, any twitching of the eye, or muscle fatigue or atrophy. So for the extraocular movements, I'm looking for ptosis for like eye drooping, or nystagmus for like the eye twitching, and any reduced vision or depth perception. And we're going to be doing this with the H test. And so Stephanie, I'm going to ask you to focus on my finger and follow my finger to each point that we come to, okay? All right. You can follow this finger. Sorry about that. There you go. Next, we're going to test for cranial nerve 5, which involves 3 tests. We're going to palpate the temporal and the masseter, the chewing muscle, when she clenches her teeth. And the cranial nerve, we're going to have her open her mouth, and I'm going to apply a resistance under her jaw and note any deviation. All right. All right, can you open your mouth for me, Stephanie? All right, no deviation noted. All right, close your mouth. Thank you. Next, we're going to check for pain sensation and ophthalmic and maxillary and mandibular division. So we're going to change the maxillary, mandibular. Are you having any pain?
No.
All right. Next, we're going to do the light touch. Now, close your eyes. I want you to tell me what you feel, okay? Also going to inspect the patient's face at rest, and I'm looking for any forehead wrinkles, nasolabial folds. I'm going to have the patient frown for me. Thank you. Can you raise your eyebrows? And can you squint? And furrow your brow? All right, and smile for me. And can you stick out your tongue for me? And now can you puff out your cheeks? All right. No asymmetry or lateralization noted upon exam. So doing your auditory acuity, Stephanie, I'm going to whisper something in your ear at a close distance and at a longer distance, and then I just need you to tell me what you've heard, okay?
Alice is wonderful.
Okay, she said Al was wonderful. All right.
Stephanie is the best.
Stephanie is the best. Yes.
Stephanie is the best.
All right. So that was positive in multiple ways. Well, next we're going to do that test for the uvula and her gag reflex, and that's cranial nerve 9 and 10. We're going to inspect the palate and check symmetry. I'm going to ask her to say ah, and I'm going to visualize that uvula, and I'm going to see if it's moving upwards. Any deviation that I'll be noting. Stephanie, can you say ah? All right. Next, we're going to assess the movement of Stephanie's tongue, and I'll be cranial nerve 12. I'm going to observe her tongue in place and ask her to stick it out and see if there's any asymmetry or any deviation or fasciculation, moving the tongue side to side. Stephanie, can you stick your tongue out for me? Next, we're going to test spinal accessory nerve, and that'll be cranial nerve 11. Okay, Stephanie. Can you shrug your shoulders against resistance? All right. Then can you turn your head this way for me? Alright, same over here. Alright, good job. Okay, next we're going to assess Stephanie, listening to her voice and articulation. This is just, I've been doing this throughout the exam, and that's testing cranial nerve 5, 7, and 10, and 12. We're going to move on to assess for Stephanie's neck, and we start off with the exam by visualizing and inspecting her neck. So I want to inspect her neck and make sure, again, that there's no edema or any mass, and I don't see anything, and now I'm going to palpate. And so no edema or visible pulsations or visible mass or irregular alignment or discoloration. Flex her chin and then extend her chin, and then lateral movements from the right to the left. Can you do that for me, Stephanie? Flex your chin. There we go. And then extend, and then to your right and left. All right, no discomfort with that. And now I'm going to palpate the lymph nodes, and we're going to do your occipital, and then I'm going to do her post-auricular, pre-auricular, parotid, and then the retropharyngeal, her tonsillar, and then her submandibular, submantle, her anterior clavicle, and her posterior, and then we'll do subclavicular, and note their location and their size, and any irregularity or tenderness, and the consistency of all of her lymph nodes. And I did not notice any asymmetry. Did you have any tenderness?
No.
Next, I'm going to palpate and auscultate Stephanie's carotids, and I'm going to do so. You do not have to do, you can omit auscultating your carotids if they are of younger age and no history. But since Stephanie does have a history of hypertension, I'm going to do so. So first we're palpating, and I'm doing so in palpating to make sure that there's no abnormality. When I listen to her carotids, I'm going to listen to with the bell. And when I just palpated, I'm looking at the auditory, and there were 2+, and which was an expected finding at 67 heart rate. No brewery noted. I would want to do this sitting and lying down, and we'll do that when we reach the next assessment. I'm also next going to palpate her trachea and notice for any deviation. No tracheal deviation. Next will be observing her external jugular and internal jugular. The patient, I'm going to get her to sit prone and then supine afterwards, and we can do so if we have a ruler. We're able to assess the jugular venous pressure and to position the patient when she's in supine or at 30-degree angle. We do not have those rulers today, but that is noted that we can perform that assessment. So first I'm going to visualize the top of the vein, and then I would measure to the top of the jugular vein, and I know the normal would be 3 to 4.5 centimeters. So I do not notice any JVD. All right. Next, we're going to inspect the thyroid gland. I'm going to inspect and palpate and make sure to assess for any goiter or abnormalities, and I do not see any. Now we're moving on to the respiratory portion of the exam. I'm inspecting her thoracic cage. I'm going to have you turn this way for me, Stephanie. Thank you. And no abnormal symmetry, no visible abnormal findings, no rash or lesions noted, and no evidence of trauma. And we're going to assess the AP diameter as a normal. Next, we're going to check the post-thoracic area. I'm going to palpate for tenderness and other abnormalities like crepitus, okay? Alright, next I'm going to assess for the respiratory expansion, and this was like before. I'm going to do this at the 10th intercostal space, and I'm going to ask Stephanie to take a deep breath in. Next I'm going to assess for tactile primitus. Okay, there was bilateral expected primitus, and I'm going to check the same on her anterior chest, and so we're checking for increased consolidation. Alright, and we would do the same on the anterior chest. Next, I'm going to look for diaphragmatic excursion. I'm going to start by palpating for the first level of dullness. And then I will make a mark on the first level of dullness. And that was at rest. And then I would like Stephanie to take a deep breath in and hold it. And then I'm going to mark the next area of dullness. You can breathe out. And then I'm going to want to measure. And measuring in centimeters, her level of dullness goes down to 4 centimeters. And I would want to do the same and do the same assessment on the other side and make sure that it is equal bilateral. Next, we're going to assess the lung. I'm going to auscultate the lungs, and I'm going to do this from the basis to the apex. And we're going to just ask her to breathe just a little bit heavier than she normally does. I'm going to do this posterior and anterior. And we're looking for the quality and intensity of her breath sounds, and I'm looking for any bronchial or bronchiovesicular breath sounds, crackles, wheezels, or friction rubs, any adventitious sounds or abnormal sounds. Okay, next breath. You want to listen for one full inhalation, exhalation. But for exam purposes, I'm moving a little bit faster. And I'll go lateral and further all the way to expand to her full lung fills. Again, we're listening for vesicular breath sounds, which are low pitched or decreased when the lung is displaced with emphysema or pneumothorax, or fluid, a pleural fusion for bronchial when the fluid is in the lungs like pneumonia. And I've noted her breath sounds are present in all lung fills, and they were equal bilateral without any adventitious sounds. Next, I'm going to move on to the anterior chest. So after we just listened to her lungs, and then we've already gone through the tactile primitus, and oftentimes like a louder and clearer sound are called bronchophony, and then the 99 you should hear a muffled sound, and I heard a muffled sound with Stephanie during her assessment on posterior and anterior tactile primitus. And so again, I'm going to use this and palpate with the ball of my hand is where you would like to assess for the tactile primitus. You can also take and palpate. Next, when I'm inspecting her chest, I'm going to look for any abnormalities, asymmetry, any obvious deformities. Previous scars can indicate past surgeries like open heart or cabbage. Any discoloration in the chest, sometimes that can signal like cues for like a mitral stenosis, so it's called a molar flush. Next, I'm going to assess for thrills and pulsations. I'm going to do this palpating and placing a hand near her heart and her sternal border and at the apex. And I'm going to observe for the thrills and lifts and heaves and note any kind of location or size or duration of any of these abnormalities. And then okay, and then sorry about that. My findings were amplitude was brisk and tapping fifth intercostal at 3 centimeters. Next, I'm going to palpate the apical pulse. This is important for the point of maximum impulse, and so I would draw a line down and palpate, the apical pulse. So this is important because sometimes patients with dilated cardiomyopathy, their PMI may shift laterally. Next, I'm going to percuss the chest, and I'm just percussing for flat or dull sounds, and that usually indicates a pleural effusion or pneumonia. And then I'm going to palpate and make sure I hear hyperresonant that can be for emphysema or pneumonia. Then we're going to assess and auscultate the pericardium, and we're going to look at the aortic pulmonic and the second pulmonic area in the tricuspid and mitral and apical. We're doing this for our landmark, so we have aortic, pulmonic, and your second pulmonic area, and then your tricuspid area and your mitral. Again, when we're auscultating, we want to listen for any additional sounds. We just want to hear S1, S2. If we hear any S3 or S4, that needs to be noted. S3, you can often hear like with mitral murmurs, and we're going to have Stephanie sit up, and I'm going to listen with my bell of my stethoscope and my diaphragm. And we'll do this sitting up in supine, and often times sitting up, I'm going to have her lean forward and have her exhale and listen with the diaphragm at the third and fourth intercostal space near sternum. I'm listening for aortic murmurs there. And then I'll have her turn on the side where I'll be listening for mitral murmurs. All right, Stephanie, I'm going to start my bell and verbalize that I'm also going to listen with my diaphragm. Starting with the aortic. I'm also listening for gallops and murmurs, friction rubs, valve clicks. Listen to the pulmonic. These are located in the second intercostal space. I'm so sorry. Alright, I'm going to have you lean forward, and I'm going to listen to the apex of Stephanie's heart to make sure I don't hear any aortic murmur. And then I need you to roll on your side toward me. Okay. Again, only S1 and S2 heard. No gallops, murmurs, or friction rub was noted. Next, we're going to check her pulses while Stephanie is staying and laying down. So first, I'm going to start off by assessing her temporal, and no abnormalities noted in her temporal when I'm inspecting, and then palpating. And then I want to assess for any bruise. And I would want to do so bilaterally. The same for the carotids. And then we'll check for the pulses. There was no bruit, no thrill. Amplitude was 2 equal bilateral, and it was expected normal rhythm with a rate of 67 consensually.
So I'm going to go ahead and check her radial pulse. I want to check bilaterally. And then I'm going to check her brachial pulse. And then I'm going to check her femoral pulse.
do the assessment of the abdomen. So it's important exam is to empty your bladder prior to this, and for inspection I'm looking for any hernias or any abnormal pulsation or contour, and see if her abdomen is scaphoid or protuberant, and Stephanie is within normal limits. And then I would like to auscultate her abdomen in all 4 quadrants. I'm listening for bowel sounds. For her umbilicus, I would assess in the 4 quadrants. Alright, next I'm going to, we have positive bowel sounds in all 4 quadrants. Next I'm going to listen for bruits and in the renal artery and the iliac arteries in the femoral. And I'm going to auscultate the abdomen's aorta and see if, make sure we don't have any pulsations noted. In our inguinal. Palpating for any pulsation. I'm going to assess for any pulsation or a mass, and that could indicate a aneurysm. And anything larger than 3 centimeters is considered to lead toward the diagnosis of a abdominal aneurysm. But there's no bruise noted renal, iliac, femoral arteries. Next, we're going to assess the superficial inguinal nodes. We'll do the superficial because you can't assess for the posterior, but we're going to palpate by rolling my I'm going to verbalize this assessment, but we're going to palpate by rolling my fingers horizontally over the inguinal ligament, and then I'm going to do it vertically over the femoral artery. Next, we're going to percuss the abdomen in all 4 quadrants. And then next we're going to assess the liver span, and doing so we're going to the mid-clavicular line, and you kind of grip your hands on the top, and I would grip my hands on the bottom, and you would want to measure, and usually it's within 6 to 12 centimeters. I feel like if I would gripped a little bit more, Stephanie's is right at 6. Perfect liver. So next we're going to, we've already percussed the abdomen, but we'll check for abdominal reflexes. And this is good for any rebound tenderness to note, but if I press down, do you have any pain or tenderness anywhere? No. All right, next we're going to palpate the abdomen, and this we're going to assess we're going to do light palpitation first and then deep palpitation. So we're lightly palpating at the right costal margin, and we're going to press firmly to assess for the liver, and then we're going to ask the patient to take a deep breath. This will give us an idea of the margins of her liver. Can take a deep breath. All right, and exhale. It's not abnormal for it to slip under afterwards. You want to palpate for the spleen. The spleen is not supposed to be able to be felt, and if it is, that would indicate some enlargement and abnormality. We've already palpated her abdomen for any possible aneurysm, and noting one that is greater than 3 centimeters is suggestive of aortic aneurysm. We have 2 other valuable assessments that we use often, and this is for appendicitis, and that can be the Posey sign, where you would flex your knee and flex your right knee and against resistance, and then they would have pain in the right lower quadrant. And then the obturator sign, when you rise, the patient's right leg and the knee is flexed, and then you rotate them laterally. So you would just pull the patient up and then roll her laterally like so, and the patient will experience pain right here in the right lower quadrant. We also want to check for any shifting dullness that could indicate ascites. That's with the fluid. If you roll to the side, it would become dependent. So then, Stephanie, I'm going to have you sit up for me, and we're going to assess the costovertebral angle, okay? And so right at your costovertebral angle, you're going to do a sharp brisk percussion or strike to the costovertebral angle and note any tenderness or abnormalities. And none were noted there. Next, we're going to start with the musculoskeletal in the upper body and neurological. And we're going to do so by assessing Stephanie's arms first, and we'll do this by examining her skin and her muscles, and just by inspection and looking. I don't see any obvious edema or any lesions or irregular alignment, and no discolorations, okay? And then no atrophy or hypertrophy. Stephanie, can you describe both of my hands and squeeze this time? Grip strengths are equal bilateral. And next I'm going to assess her hands and her arms, and by doing so I'm assessing for pain and sensation, any vibration and light touch. And I can do this with a pinprick. Can you tell me what you feel?
No. 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 Okay. Sorry. And then describe it. That ready? You done? What are you done?
And then we have pain. This is just a tool just to let light.
And touch.
We're going to also assess for stereogenesis, and I'm going to ask Stephanie to close her eyes, and I'm going to place 3 different objects in her hands, and she's going to describe what each object is. Can you tell me what you feel?
Key.
All right, that's correct. And we want to do it bilaterally on the other hand. Stephanie, can you tell me what that is?
Pen.
Mm-hmm. All right, that's correct. And then, Stephanie, can you tell me what that is?
Paper pad.
So next, we're going to assess Stephanie's coordination and observe for rapid alternating movement and pinpoint testing. Stephanie, can you do this for me and mimic? Can you do hands up and down? Okay, next we are going to assess deep tendon reflexes. This is in the biceps, the triceps, and the brachial artery, and the patellar and Achilles and Berbinsky's. And just lightly hang. And then I'm going to let you move toward the end of the bed. Alright, so we've just checked the patellar, taken the Achilles. Next, we're going to inspect and assess and palpate Stephanie's shoulders, and we're going to visualize and palpate for any abnormalities. And no edema or any visible abnormalities, and alignment looks correct and no discoloration. Next, we're going to check your elbows, and we're going to check and inspect and palpate your elbows. And the same thing, we're checking for any abnormalities, asymmetry, disalignment, atrophy, any internal rotations and such. So first, I want you to externally rotate, internally rotate, flex your shoulders upward and show them downward, and then lateral, and then your left also. So I want you to flex your wrist for me. So flex, extend. I want you to do pronation and subnation. And noting that the capillary refill is less than 2 for Stephanie, and her nail bed is nice and pink and moist, and she has no discolorations or any abnormalities noted to assessment of her nail bed. So we're going to inspect Stephanie's legs. And for Stephanie, I would document no visible abnormal findings, distortion or swelling, discoloration or skin thickening, ulcerations or varicose veins. Then I would assess the range of motion for Stephanie, and range of motion of her hip, and that would be for adduction, abduction, flexion, hyperflexion, internal rotation, and external rotation. Start with adduction, pull it outward, and then the next leg. And then you're going to go with adduction. You're going to hyperextend. You're going to internally rotate. And internally rotate. And then externally rotate. And then externally rotate. And flexion and hyperextension. I'm glad you're agile because this could work for a problem. We're going to inspect and palpate her knees and assess for range of motion for extension and flexion and extension and flexion. And notice, and you can palpate the patellar and palpate for any crepitus or abnormalities or pain upon palpation. Also, we can assess for the ankle brachial index, and usually that's normally like 1.0. And so I'm going to ask Stephanie to flex her foot and then hyperextend her foot, dorsiflex, flex for me, and then dorsiflex, internally rotate, and then externally, and then abduction, which will be outward, and then adduction. Alright, is any pain or tenderness you've noticed in your calf? I would assess her lower extremities for symmetry and any swelling, and just assess for edema. I would next assess her pulses, and I would take her shoes off at this point, but don't feel like she'll feel comfortable with that. So by doing so, I'm going to check her dorsalis pedis and her popliteal and her posterior tibial. And so I would also check her toes for her capillary refill, and I would assess for any polar stenosis or spider hemorrhage or clubbing. So Stephanie, I would like you to push up against my hands with your feet. Okay? And then push down like you're pushing a pedal. Okay? And then push, try to pull your leg up against the resistance. There you go. Again. And then same with your arms. I want you to close your eyes too. Push against. And then push against. That's your hands. Push against. And then push. Alright. And we did your neck and your shoulders for resistance too. The next and final part will be assessing Stephanie's gait. And we're going to look at this at a standing position and note the height of her shoulders. We're looking for any asymmetry or off balance in her gait. We're going to look at the iliac crest, scapulas, and note any of the alignment. Can you go from that door and walk for me? And right when I'm doing this, I'm observing her posterior, and then you can walk toward me, and the anterior. I'm palpating the spinous process and no irregular alignment. I'm palpating it when she's spine too, okay? I want you to lateral bend, and then rotate for me. And then flexion, and then hyperextension. Any discomfort with that, Stephanie? So next, with your feet together, and not swaying and your eyes closed, I just want you to check for, we're checking for your Romberg's test, okay? All right. And then next, we're going to assess for the heel to toe walking and the walking on tiptoes. So I'm going to let you walk heel to toe, and then walking on your tiptoes back and forth. And this is assessing Stephanie's balance and So this has able to see balance and coordination. And Stephanie, I've enjoyed the assessment. Ends our head to toe assessment.
Thank you.
Thank you.